So innovation is one of my favourite subjects, and I'm particularly passionate about helping people to understand how they can be innovative. And I take my learning from around innovation methodology from design. It's a basic design methodology, and the thing that I think is most important about that is at the very beginning of this innovation design methodology, a core component is to understand people's perspectives. And so that's the patient perspective and the staff perspective. What is it like for me as a staff member to deliver care? And what is it like for me as a patient or family member to receive care? And you'll hear the term patient-centered care, patient and family-centered care, experience-based design, experience-based co-design. And one of the things I learned when I went to New Zealand is they have a particular term that they use for family. And so we'll describe it as patient and whānau-centered care. Whānau is the Maori term for family, and it's just one of those terms that gets used very naturally and is always called whānau. And so what we make sure that we do in our innovation methodology when we're trying to explore challenges, when we're trying to reach a point where we can start innovating, is we start with patient and whānau-centered care. And that means we really start to work with those people to understand their experiences of receiving the service we're providing. And of course, as I said before, we also work with staff in the same way. That helps you really understand the challenges and the problems. And data, traditional data to that mix. And that mix is often storytelling. We use films, we use narrative, any way to capture a story about how it feels. We might add in the clinical data to that, and it gives us a whole view of what the challenge is. And then we work together with patients, staff, family members, whānau, to say what are our ideas to improve. And that's where the term co-design comes in, because that's us together designing. And co-design doesn't mean only patients designing or only staff. It's together. If we're trying to improve our services, and if we as clinicians and managers, healthcare workers, only take the ideas that we come up with or implement them in the way that we believe they should be implemented, we are at risk of not designing and implementing the service that is going to really meet the needs of the people. So to co-design, it means that we've got a stop check all the way along from the people who we're trying to, give a great experience to, as well as great technical care, so that they are making sure what they need is incorporated all the way through. And again, as I say, it is for patients and staff. So doing it together means we can create the best service, best processes that make it as easy as possible for staff or as rewarding as possible, and equally a great experience for patients and whānau. When I was in the UK, I did a lot of work, and here we called it experience-based co-design. And I've taken that learning into New Zealand and learned more as I've been using it in New Zealand. I think the challenges are really, really similar. There's sometimes a fear that if we ask patients what they'd really like and how would their experience be changed, then they're going to ask for something that we can't provide. And to be honest, I don't find that. And even if there is something provide a bigger car parking always comes up, provide a bigger car park because I can never find a way to park. There's a sensible adult conversation here, and patients, if you talk to them sensibly, they'll say, okay, I can understand that, it would still be on my wish list. But if they say, gosh, I really get lost every time I come, or I have this leaflet and I don't understand what it means, we can together do something about that. The other, I think there's a nervousness sometimes from staff to say, well, we don't know who to pick. Patients do we pick, and how do we approach them? In my experience, it's not an exact science. If you're working in a ward or in outpatients or in any other area, actually patients, if you just go and approach them, are often quite happy to talk to you. But, if they don't want to, that's fine. You can start to talk to patients who've complained because they've got something very relevant to say, and they often are really, really helpful. They tell you what's not worked well, but equally they tell you what's working really well, so that we can build on what is working really well and help improve what's not working well. There is also an anxiety about time. I haven't got time to get stories from patients, and what we're trying to do is teach people that actually by asking one or two simple questions in my daily routine, while I'm doing other things, that's the time I can use more effectively than I am now. And one of those simple questions is, how are you doing? How's it been today? What matters to you about this admission? What happened? What matters to you about when I come and do your dressing in your home? What matters to you? And that simple question gives a real insight into how we can plan care to support that person in the best way. We are all capturing data about patients anyway, so build it into your routine. And if you're writing a care plan, you can capture that data within the care plan. Some of the ward teams use specific forms so that they can capture and then look over time. They have speech bubble type post-it notes, sticky notes, and so they can capture that and stick it on a notice board. Some people, again with permission, take little video clips just with a ward iPad or smartphone. We have to get permission for those, or even audio recordings, and then use that feedback in team meetings to help everybody understand. We also, one of the things that we've done with colleagues in the hospital is changed our patient safety leadership round. So it used to be that the main conversation was with the staff, and we'd look at the safety boards, and we've changed that because we thought that's not really good enough. So now it's a tripartite approach, really. We look at the environment, we walk into the ward and we smell and we look to see if it's welcoming and get a sense. So 2 people do that, environmental scanning. 2 people will talk to staff members, at least 2 staff members, but more, often more. And 2 people will talk to patients and whānau to get their experience and talk to them about how they perceive safety. Do they see people washing their hands? Are they worried about anything? And so we then will record that in quite a formal way and play that back to the ward. And the staff or department, we do it in both areas. And staff have said, actually, it's phenomenal getting the feedback, particularly from the patients, and understanding what they notice. They're sitting there just noticing things lots of times, and what they appreciate. And so, I think this is not about saying, okay, this is the way we routinely do care, and by the way, we'll capture patient experience here and monitor it differently. This is about thinking about how we can embed understanding the patients and staff experience into everything we do as routine, because then it becomes not a standalone thing, it's something that we do around here, and that's what we want, that cultural change.